This is the part that's exciting to me. Data's great, the stroke program's great, but it's the outreach that we do. And when you look around the room, this is our outreach. So let's get started. I do not have any conflicts of interest or disclosures to tell you. I work all the time. So goals and objectives. Define teleneurology, including the benefits and challenges. Give an overview of the Cottage Hospital Teleneurology program. Define stroke outreach, including the importance, who is involved, and where it occurs. And discuss the future direction of teleneurology. So just a little bit, I know Dr. Ohanian kind of went over teleneurology with you guys in the neurology hospitalist group. So we're going to talk, neurological consultation is a consultation at a distance. It's not at bedside with the patient. It can be done by internet, it can be done by phone, and it can also be done by robot. And with that, from teleneurology, we look at telestroke. So we're very specifically looking at our stroke population. And what's really exciting and interesting is in 2013, the American Stroke Association listed telestroke as part of their guidelines. That's really a big deal because that's what we use to look at our clinical practice guidelines. So according to the ASA, implementation of a telestroke consultation in conjunction with stroke education and training for healthcare providers can be useful in increasing the use of IV TPA. In other words, we want to get these patients treated quickly. So there's some benefits and challenges to teleneurology. When you think of the benefits, rapid triage, that's the idea. Stroke is time sensitive. We want to identify it quickly and treat quickly. So the rapid triage and determination of IV TPA and interventional candidacy. Specialized stroke neurologist. How many communities do not have a stroke neurologist? That's a really big deal. If you're that patient, who do you want taking care of you? A neurologist, if that's what they're really specifically trained. That's who I want. And then also, really important is that we want to identify the patients that can stay in their own communities. We don't want every patient transferred for higher level care if the community hospital can take care of that patient. So if they don't need an intervention, wouldn't you rather be closer to home? The patients would, their families would, and then they'll get the follow-up in their local community. Reduce liability if you're an ER physician and you're trying to make that determination of whether this patient needs TPA or not. Wouldn't you like to have a stroke neurologist on the other side of that computer saying, yes, this is definitely a TPA candidate? And it makes them feel better. It also makes the patient feel better because they have a neurologist saying, yes, please treat. Patient satisfaction's improved. Quick treatment decreases the patient's disability, and that's what we're all here for, is great patient care. And the really important thing that a lot of people are looking at is the reduced door to needle times for TPA administration. Just like what was said earlier is now, instead of 60 minutes, it's 45 minutes that they're really pushing. I think within a year, it's going to be down to 30 minutes. That's very quick. When you think of everything that occurs whenever that patient arrives, whether they walk through that front door or whether they come by ambulance, a lot has to happen. Registration alone can take 5 minutes. We all know that. The paperwork, getting them in, getting their vital signs, getting the CT scan ordered, getting the doctor to assess them, that right there can suck up a lot of your time. Challenges, though, nothing's perfect and nothing's easy. So you think about the clinician perceptions. You know, why should I have a doctor that's at home in their pajamas behind the computer monitor be the one to tell me whether I should treat this patient? Why am I not good enough? Okay. Patient perceptions. You know, you would think that the patients would not be excited about having a doctor on the other side of a computer screen taking care of them. I've worked in several organizations that did telemedicine. The patients think it's really cool. The fact that they're getting a neurologist, that's what they want. They don't care whether you're standing at the bedside or you're coming through a computer screen. That's who they want. Licensure, certification, and credentialing. Most organizations find that that's the biggest challenge. Getting physicians that are not local in their community credentialed. It's a huge process, and it can take up to 3-4 months. So that piece of it is always a challenge, but that's with any physician being credentialed in any organization. Assessing competency. Nurses, we know how we get assessed on competency. How do you assess a physician's competency? Another challenge. And then cost. Because with this comes, how are you going to do telemedicine? There's the robot cost, there's the connectivity cost, physician cost, contract cost. So that's something that every organization has to look at and look at the return on investment to determine, is it worth it? Patient outcomes. To me, that's worth it. And then overall medical staff buy-in. You have to have the buy-in by the physicians, not just the ER physicians, but also the hospitalist that will be taking care of these patients if they're not transferred. They have to feel comfortable with taking care of post-stroke patients. Okay, so that's something that we always need to consider. So Dr. Ohanian kind of talked about the hub and spoke model for telemedicine, and this is our current one here at Santa Barbara Cottage Hospital. And as you can see, there are 6 spokes. Cottage is the hub. We have Twin Cities Community Hospital. We have Lompoc Valley Medical Center, San Ynez Valley Cottage Hospital, Santa Paula Hospital, Ventura County Medical Center, and then also we have Sierra Vista Regional Medical Center. So these are the organizations that are using telemedicine through our neurohospitalist to see their patients. And like Dr. Ohanian said, what's really great is that the neurohospitalist that goes on the robot to assess the patient will then be the physician accepting the patient here at Cottage. So you have that continuity of care. You don't have to worry about the handoff, and it works really well. So telemedicine gives a more accurate diagnosis, increased utilization of proven therapies. There are some organizations that did not give TPA until they got telemedicine because they did not have neurologists. Lompoc Valley, great example. They went from doing no TPA to 1 month, they did 5. That's exciting. Think of the patient outcomes and lives that they've saved. Improved triage. There can be a delay from when the patient comes in, they use telemedicine, they get the neurologist on the phone. That's still quicker than if the neurologist is at home in bed, they have to get woken up, they wait until the CT scan comes back, they get in their car, and they drive to the hospital. You're probably not going to make that 60-minute door to needle time. Better utilization of vascular neurologist. These patients can get assessed if they need to go to a higher level of care for endovascular care. Opportunity to partner. Look at all these organizations that we've partnered with within the last year. That's really exciting. And then opportunity to impact care quality. Ultimately, we're all here for the patient. We want to give great patient care. Stroke outreach. This is the part that was really exciting to me. And when you think about stroke outreach, it's partnerships. It's partnerships with other organizations. So this is the part that I am excited to do. So I would like to acknowledge all our stroke partners. So when I name your hospital, please stand up because I want everybody to look around to realize how much of an impact we're having. So Twin Cities, is there anybody here from Twin? Yeah, yay. Sierra Vista, Arroyo Grande, French, okay, Marion, okay, Lompoc, San Ynez, Goleta, Community Memorial, Ojai Valley, Ventura County Medical Center, Santa Paula, St. John's Regional in Oxnard, and then there's also St. John's Pleasant Valley. So when you look around, this is what it's all about. This is what stroke outreach and stroke partnership and telemedicine is all about, working together to improve patient care. So thank you guys for everything that you do, and I've enjoyed working with you guys over the last year. We've got so much more to do. So education is empowerment. You know, we can't get better if we don't learn and we don't work together. So I'm the first person to say, if I have something that you need from me, please ask, because I'm more than willing to share with you, because it's not a silo. If you do something better than I do, I want to know about it. So I think this is part of the fun part of this, is that we all get to learn from each other. Empowerment is to do the right thing for the patient. Ultimately, that's why we're here. That's why we're in the healthcare profession. And then we really do take this role very seriously here at Santa Barbara Cottage Hospital. And we make it a point to open up all our opportunities to the communities and the other hospitals. A couple of examples that we do, is saving the brain. Here you are. This is awesome, and hopefully you have the save the date bookmarks, November 3rd next year. Okay, so everybody go ahead and put that on their calendar, and I hope to see all of you here, plus a lot more, okay? We also have a SBNI lunch lecture series. And then we also have the neurotransmitter. So with the SBNI lecture series, we do that through teleconferencing. So other organizations are able to beam in. Physicians, nurses can get credit for being there. And we have amazing lunch series. So we will have our next year's up hopefully soon. So just a little bit about Santa Barbara Cottage Hospital. We are an advanced primary stroke center, Joint Commission accredited. We have about 351 beds available, over 2,200 full-time employees. We have a neurohospitalist program, neurocritical care unit, neuro step-down unit, intraoperative MRI, endovascular procedures, and much more. So just a little bit about what we do. So when you look at Santa Barbara's numbers, it kind of gives you an idea where we are with our total stroke cases. We're kind of hanging in there in the 600s. We just go to the 2015 data. We haven't got this year completed. We went down a little bit in 2014, and as you know, ischemics, there are more ischemics than there are hemorrhagics. And then what's exciting are the TPA cases that we've done. If you look in 2013, there was 29, 14, there was 22. 15, we did 30. We've done 38 so far this year. And these are just the ones that we have initiated TPA within our organization. The number of patients that we receive from all of our outreach organizations, we wind up taking care of and monitoring, doubles that. Okay, so I think that's exciting that these patients are getting top care, quality care. With our neurohospitalist program and our telemedicine at night, I think that has also assisted because, again, you don't have that community neurologist at home that you have to wake up. They don't want to know until the CT report's back, and then that delays. So that's great care for these patients. Communities we serve, that's a really large area. When you look at it, it's 3 counties that we are serving. And it's a lot of territory to cover. So 44% of our stroke patients here at Santa Barbara Cottage Hospital come from outside our primary service area. That says a lot. So without you guys doing amazing care on the front end, our numbers would be half as much. And that's what we want to make sure that we're getting the appropriate patients. We want the ones to stay in your community that can stay in your community. That's very, very important. And then that kind of shows you where all the hospitals are. We're all along the coast. There's no other, advanced primary. St. John's is doing interventions, and then Los Robles is the next one. So when you look at kind of the map, it's a very, very large territory. So talking about telestroke and some of our data. So on the left is the Teleneurology robot consultations. That's when the physician actually beams in to the ER. And the one on the right is just a phone consult. Not every patient that the teleneurologist is contacted for gets the robot. Okay, so when you look at it, when we started in January, the number of robot consults, pretty significant, over 60 in a month. That's a lot. And then when you look now in September, where we're at, we're less than 40, like around 35-ish. That just means that the teleneurologists are being used appropriately, and not every patient needs that eye-to-eye consult. Just like in any ER that you do have a neurologist. Do they come in to see every patient? They don't. So that just means that the physicians have gotten better when you look over at the numbers for the phone consults at the appropriate use of the robot. And just like any new toy, what do we want to do with it? You want to play with it, right? You want to make sure it works. You want to see what it does. It's the new toy. So you have to play with it a little bit. It's okay. So that kind of just shows where we're at. Transfers to Santa Barbara Cottage Hospital. The one on the left are our telemedicine partner hospitals, and this is as of the end of August. If you look, the red is 2015, 16 is the projected. To me, what that is saying is that the appropriate patients are getting transferred down here to Santa Barbara, and that you guys are able to keep a lot of your patients. As we should. We want you guys to keep as many of your patients that are appropriate. And then you look at the non-telemedicine partner hospitals, we have quite a few of those, and the same thing. It's decreased in the number of transfers. We're okay with that. We don't want every patient. We want appropriate patients, and we want you to keep your patients. So I have a couple little quick case studies. It kind of goes along with our telemedicine talk. So when you look at this, it's a 77-year-old male found prone on the ground by their neighbors. Last known well, 11:10 in the morning. Arrived at Sierra Vista ER at 12:39 via EMS. The glucose by EMS is 115 because, as we all know, it's really important to make sure they're not hypoglycemic, and that's why they're altered. When they arrived, the NIH was 14. Past medical history, hypertension, previous stroke, and hyperlipidemia, 3 of our risk factors, right? You think a ticking time bomb? There you go. So with the NIH score, they had a 1 for level of consciousness questions, 1 for level of consciousness commands, 1 for gaze, 2 for facial palsy, 4 for left arm motor, 4 for left leg motor, and 1 for dysarthria. Okay. They did a CTA, and it showed a distal right ICA occlusion. They consulted Dr. Zahner, and the patient wound up getting transported at 14:17. The important thing is they got TPA. They got TPA in a 60-minute door-to-needle time. Okay, we still made the 60 minutes, so they received it at 13:39. What I think is impressive is from 13:39 to 14:17, that's a really fast needle to door, out the door time. Okay, and it was a 98-minute door-to-door. Okay, as we all know, transportation of these patients is very difficult. You can't always fly them because of weather or they're out on another call. Critical care transport is a challenge because usually there's one in an area, and if they're out on another call, they can't get to you. Then do you send your own nurse? Does your organization allow that? So those are some challenges that we still have to work, and I think that's one of the things with the stroke outreach and partnership that we can work together to hopefully figure out some solutions. So the patient got to Santa Barbara ER at 15:17. So it was a 60-minute transport time. When they arrived at our ER, their NIH was 19. Initially, it was 14. The patient did have some worsening LOC during transport. When they got there, we did a CT perfusion scan. It showed a deficit in the right posterior cerebral artery territory. The patient did go to the angio suite. They had a large thrombus in the right ICA with no flow to the right PCA. Thrombectomy was done with a stent retriever and aspirator with complete recannulization. So part of the stroke workup, as you all know, is you've got to find a cause. What's going on and why did this patient have the stroke? The patient was having multiple PVCs throughout their stay on telemetry, so the cardiologist felt that it was a great idea to put in a Reveal implantable heart monitor to see if the patient's having AFib that we just didn't catch. The patient was also discharged on Xarelto. We'll be on it for 6 months for sure, and then if they find AFib, then longer. They were discharged back to AG rehab. They went back to their community for rehab. That's excellent. That's what we want. Partnership, get the patients back into their community. So the diagnosis was a right MCA stroke, cryptogenic embolic event. Their NIH on discharge was 6 with no dysphagia. They were alert and oriented times 3. They had mild left facial droop and moderate left-sided neglect, but they were a very good rehab candidate. So another one. Last known well was 1930. They got to Lompoc at 1942 by EMS. Past medical history, heart disease, hyperlipidemia, hypertension, AFib, not on any medications for the AFib, and AICD. Glucose was 105. NIH was a 4, so it wasn't a really high NIH. Teleneurology consult via the robot, so it was a 19-minute door to neurology consult. That's pretty good. TPA was administered, 47-minute door to needle time. Very good. And then transport via CCT, so they got TPA at 2029, they were out the door at 2041. The key to this one is that they contacted the CCT ambulance company, AMR, whenever they thought the patient was a possible TPA candidate. They started rolling, they didn't have another call, so they were there when the TPA was being given. So they got to our ER, it was a 77-minute transport time. When the patient got there, NIH was 2. It originally was a 4. So we did have some improvement. We did a repeat CT, which was still negative. Stroke workup was negative. The patient was AO times 3 with some mild dysarthria in language with occasional paraphasic errors, but mostly intact. Trace right-sided nasal labial flattening was very difficult to differentiate, and a little bit of clumsiness in the right hand. He was cleared by PT and OT to go home with outpatient PT-OT. Was started on Eliquis and Plavix. So that's great. Patient got to go home. That's what we all want. And then the third case, 63-year-old female, found by her husband to be altered, right facial droop, slurred speech, and right hemiparesis. Last known well time was 2200. Got to Santa Paula ER at 2250. These are some pretty quick ALS times from onset of symptom that they noticed to dial 911. That's really good. That's one of the things that we can work as a stroke outreach is to improve the community understanding of it's an emergency. So when they got there, the glucose was 163, past medical history, diabetes, hypertension, and new set AFib whenever they got to the ER. When they got to the ER, the NIH was 21. It's pretty significant. Teleneurology and Dr. Zahner both were consulted on this one. And at 23:25, TPA was administered at 23:46, 56-minute door to needle time. Okay, still below that 60. They were transported by critical care transport. It was a 70-minute door-to-door time. So from the time they arrived to the time they went out, 70 minutes. So that's really good. All right, when they got to the ER, the NIH was 8. Initially, it had been a 21. Wow, that's significant, okay? That just shows that TPA can work. We did a repeat CT-CTA. It showed a left MCA occlusion. The patient went to the angio suite, left MCA thrombus, embolectomy, complete recannulization. The patient got to go to St. John's Rehab, so went back into their community. Their NIH, the patient had a little bit of expressive aphasia and right-sided hemiparesis whenever they were discharged. AO times 3, the modified Rankin was 4. And with the new onset AFib, they started the patient on Eliquis. So that just shows that the teleneurology program is working and that it's the whole team. It's the initial hospital doing their job, doing amazing patient care, getting teleneurology early and quickly, getting that consult in, and then treating the patient appropriately, and then transferring them to higher level care if needed. So, where are we going with teleneurology in the future? I think the sky's limitless with this. I think there's a lot that we will be able to do. One of the things in the literature right now that's kind of exciting and interesting to me is the virtual stroke unit. So some of these community hospitals will be able to keep their patients in their community with the appropriate stroke neurologist doing it by telemedicine, kind of what Dr. Ohanian spoke about. With these virtual stroke units, it allows the patients to stay at their own hospital. It fosters communication and collaboration between the hub and spoke. It allows rural hospitals to provide quality care to acute ischemic patients. And it consists of a spoke site provider. So you do have to have a neurologist there that, if there's something that you need, and the hospitalist. Hub site neurologist. You need a liaison physician and trained spoke staff. So the hospital staff, the physicians, nurses, have to be able to take care of these patients. So for some organizations that have never taken their stroke patients, that would be some education. But then again, that's what this collaboration is all about. Don't recreate the wheel. Let's work together to give amazing patient care to our communities. And thank you.